Okay, so picture this. A really serious injury, maybe a car accident, or even a surgically reattached limb.
Right.
The immediate thought is always getting the blood flowing again, isn't it? It's absolutely vital.
It is. But what if restoring that crucial blood supply could actually trigger, well, a whole new wave of harm inside the body?
That exact paradox, yeah. That's what we're diving into today.
It's called ischemia reperfusion injury, or you'll hear it called IR injury.
IR injury, okay.
Think of it this way. First, the blood flow stops.
Hmm.
That's the ischemia part.
Right, no oxygen, no nutrients.
Exactly.
Right.
Then, when it comes back, that's the reperfusion, this very act. It can set off this chain reaction of damage.
Yeah, it's wild. And for this deep dive, we've got some fantastic material. It's from Hyperbaric Medicine Practice.
Ah, yes. Good stuff.
Yeah, we're focusing on a chapter that really gets into, the nitty-gritty of the microcirculation and IR injury. It highlights work by Richard C. Benosa, William A. Zamboni, and John Brocious.
Some key researchers in the field.
Definitely. So our goal today is to really understand what's happening kind of beneath the surface with IR injury. We want to break down the key players, especially these tiny reactive molecules called free radicals.
Culprits we hear so much about.
Exactly, and see what's going on in the smallest blood vessels, the microcirculation. Plus, we'll explore how hyperbaric oxygen, HbO2, might offer a way to counteract this damage based on what's in this research.
And this isn't just like lab science, right?
Yeah.
It has very real implications.
Absolutely, for situations like severe trauma, limb replantation.
Yeah.
Really critical stuff.
So if we think about those initial moments after a severe injury, maybe high-impact trauma, a bad crash.
Or like compartment syndrome, where swelling just chokes off the blood supply.
Right, or even a severed limb they're trying to reattach. That lack of blood flow, the ischemia, it means tissues are being starved of oxygen, starved of nutrients they desperately need.
And the research makes it clear these are the exact scenarios where this IR injury becomes a huge concern.
Yep.
And it's that next step, the reperfusion, that just feels so backwards. You'd think, great, blood's flowing, crisis averted.
Logically, yes.
But as the text points out, this restoration can actually trigger what they call accelerated microcirculatory injury.
Which leads to even more tissue damage, potentially even cell death.
It's almost like trying to put out a fire, but accidentally spraying gasoline on it first.
That's a good analogy, and it raises that crucial question.
Yeah.
Why? Why does the return of life-giving blood cause more damage?
Yeah, what's going on there?
Well, the research emphasizes that certain tissues are particularly vulnerable. Skeletal muscle, for instance. It's incredibly sensitive to ischemia.
Okay.
If it's deprived for too long, it can undergo necrosis. The tissue actually dies, which leads to a significant, maybe permanent loss of function.
And that's a massive hurdle in limb replantation, I imagine.
Huge.
Yeah.
The chapter even gives this really sobering example. A 10-year-old boy, his arm was replanted.
Oh, wow.
But tragically, all the muscle tissue died specifically because of this reperfusion injury. They had to amputate again.
Oh, that's awful. That really brings home how serious this is. So, okay, if the reintroduction of oxygen-rich blood is causing this damage, what are the actual culprits?
The research points heavily towards oxygen-derived free radicals. You might hear them called oxyradicals.
Free radicals, we hear that term a lot. What are they exactly?
Interestingly, they're described as highly unstable molecules. They have an unpaired electron.
Meaning they're missing something?
Sort of. Think of them as incomplete, so they're highly reactive, desperately trying to grab an electron from other nearby molecules. This makes them incredibly toxic biologically.
Okay, so they steal electrons and damage things in the process.
Pretty much. They can cause cell death through something called lipid peroxidation.
Lipid peroxidation sounds like fat damage.
Essentially, yeah. They damage the fatty outer layers of our cells, kind of like how fats go rancid.
Right.
And worse, they can start a chain reaction, propagating more free radicals.
So one bad apple spoils the whole bunch, essentially. These rogue oxygen molecules start this invisible fire inside the tissue.
That's a good way to put it. Now, because these free radicals are so short-lived and reactive, they're actually quite tricky to study directly.
So how do researchers know they're the problem?
Well, they often use what are called free radical scavengers in animal models. These are substances that neutralize the free radicals.
Ah, okay, like an antidote.
Sort of. And the results seem pretty convincing. When these scavengers are used, studies show improved survival and function of tissues affected by IR, specifically skin and skeletal muscle.
Okay.
The research even mentions a study with a synthetic scavenger at Averone, When given preventatively, it helped reduce inflammation and stop damaging cells from moving into muscle after IR.
So that's strong indirect evidence, then, that these oxyradicals are really central to the damage.
Exactly. The chapter highlights two main sources of these troublemakers. One is an enzyme called xanthine oxidase, or XO.
XO, where does that come from?
It originates in the endothelial cells, the cells lining the blood vessels, specifically in skeletal muscle. Think of XO as a little factory in the vessel lining that starts churning out these damaging radicals when blood flow returns after ischemia.
Okay, so XO is one source. What's the other?
Perhaps even more importantly, neutrophils.
Neutrophils. Those are white blood cells, right? Part of the immune system.
That's right. And apparently, they can unleash a massive amount of superoxide, which is another type of free radical,
How do they do that?
through an enzyme in their cell membrane called NADPH oxidase.
Okay, so neutrophils arrive and release superoxide. Then what?
Well, this superoxide can then transform into hydrogen peroxide.
Hydrogen peroxide, like the stuff you put on cuts.
Similar molecule, yeah. But here, if there's iron around, which there often is in damaged tissue, that hydrogen peroxide can turn into the really nasty hydroxyl radical. Extremely reactive.
Wow, so it's like a domino effect.
Yeah.
One unstable molecule creates another, which then creates an even worse one.
Precisely. And if that wasn't enough, neutrophils also release enzymes, like myeloperoxidase, that can create hypochlorous acid.
Hypochlorous acid. Sounds like bleach.
Basically, yes.
Right.
It's a potent oxidant and might even activate other enzymes that break down tissue.
This sounds like a multi-pronged attack by these neutrophils.
It really is. And the current thinking, based on a growing body of research, is that the free radicals produced by these activated neutrophils might actually be more significant than those from XO, particularly for the kind of damage seen in skeletal muscle during IR.
So we've got these rogue molecules, the free radicals causing chaos, largely thanks to these activated neutrophils. But where exactly is this battle taking place?
That brings us to the battlefield itself, the microcirculation.
Those tiny, tiny blood vessels?
Exactly. The focus has shifted from just the chemical processes to actually observing the physical changes happening in these microvessels during reperfusion and looking at how blood cells, especially those neutrophils, behave.
So we know the free radicals are the chemical weapons. Now we're looking at the physical battlefield. What did they see?
Well, there have been direct observations using specialized microscopy in animal models, a key finding from a study by Zamboni and his team.
The name we heard earlier.
Yes. Using a rat model, they saw a dramatic increase in neutrophils adhering to the walls of postcapillary venules. These are specific types of very small veins.
Yeah, and this happened quickly.
Within minutes of reperfusion, mere minutes, and this sticking persisted for hours. Importantly, they didn't see this in tissues that hadn't had ischemia.
Wow, so the reperfusion itself triggers this stickiness. And it wasn't just that they were sticking there, right? Did it cause damage?
It seemed to. The walls of these tiny veins themselves started to appear damaged, less clearly defined, because of all these attached white blood cells.
Okay.
And under an electron microscope, which gives much higher magnification, researchers could actually see disruption of the endothelial basement membrane, that's a delicate structural layer, right next to where these neutrophils were clinging.
So the neutrophils latch on and basically start damaging the vessel wall right where they stick.
That seems to be the case. This early adhesion of neutrophils and their subsequent release of those damaging free radicals look like a critical first step. It leads to damage of the endothelial cells lining the vessel, and ultimately it can lead to the failure of the microcirculation and IR injury.
Is there a specific mechanism for how they stick? Like, how do they grab onto the vessel wall?
Yes, there is. It involves a molecule on the surface of the neutrophils called CD18. It's a type of integrin.
CD18.
And this CD18 binds to a receptor on the endothelial cells called ICARM1.
Okay, so CD18 on the neutrophil connects to ICOM1 on the vessel wall cell, like a lock and key.
Exactly like a lock and key. And what's more, it seems IR injury actually causes more CD18 molecules to appear on the neutrophils, making them even stickier.
So more keys are made, making it easier for them to latch onto the locks on the vessel wall.
Precisely. And it gets even more detailed. Researchers observed a change in how these CD18 molecules are distributed on the neutrophil's surface. They tend to cluster, or cap, at one end of the cell.
Cap. What does that mean?
Imagine these CD18 molecules are like little Velcro strips scattered over the neutrophil. When they cap, it's like all those strips bunched together on one side.
Ah, creating a super strong patch of Velcro.
Exactly. It significantly increases the adhesion avidity. how tightly they can bind to the ICAM1 receptors on the endothelium. It really locks those neutrophils onto the vessel walls.
It's a very targeted kind of stickiness then. And it's not just the neutrophils causing problems, is it? What about the vessel lining cells themselves?
That's a crucial point.
Yeah.
The endothelial cells, after going through ischemia and then reperfusion, can actually undergo cell death themselves, both apoptosis, that's programmed cell suicide,
Right.
and outright necrosis, just dying from the injury. This damage to the vessel lining itself could then contribute to all sorts of downstream problems. Vessels not working right, constricting when they shouldn't, even blood clots forming.
So the lining gets damaged, which messes up vessel function. Does this affect the tiny arteries too, the arterioles?
It does. Studies have found an imbalance in certain signaling molecules. Specifically, there's an increase in thromboxane B2.
Which narrows vessels.
Correct, it's a vasoconstrictor. And this increases relative to prostaglandin E2, which is a vasodilator. It widens vessels. This imbalance is strongly linked to microcirculatory failure.
So you get more narrowing signals than widening signals. What does that look like in the vessels?
Well, initially, right after reperfusion starts, you might see a brief widening vasodilation. But then there's this progressive and pretty severe narrowing vasoconstriction of the arterioles in the area that had ischemia.
Okay, they start clamping down.
Yeah. And here's where it gets really interesting, connecting back to the neutrophils. This constriction seems to be localized. It happens mainly in the arterioles that are right next to those damaged venules, the ones with all the stuck neutrophil.
Oh, wow. So the damage in the small veins seems to trigger clamping down in the nearby small arteries.
It strongly suggests a very local effect, yeah. Like the damage caused by those leukocytes is sending signals nearby that cause the arterioles to constrict.
What kind of signals do they know?
The specific substance causing this is still under investigation, but the chapter mentions several possibilities. Thromboxane, which we just mentioned, serotonin, leukotrienes,
Okay.
and potentially impaired nitric oxide. Nitric oxide normally helps keep blood vessels relaxed, so if that's not working properly.
The vessels might constrict more easily. Makes sense.
Right. They also mention the possibility that mast cells, another type of immune cell, might be releasing stuff that contributes.
It sounds incredibly complex, a whole cascade of interacting problems.
It really is. And this very localized vasoconstriction happening near the damaged venules could explain something often seen clinically, a patchy pattern of muscle tissue death in IR injury, rather than, say, the entire muscle failing uniformly.
So it's not global failure, but pockets of damage linked to these local microvascular problems.
Exactly. A more uneven or heterogeneous pattern of injury.
Okay, so that's a pretty bleak picture of what happens during IR injury. The damage cascade, the microcirculation failing.
It is. But the research doesn't stop there. It also explores potential ways to intervene, and hyperbaric oxygen, HPO2, seems to be a really promising avenue.
Hyperbaric oxygen. So breathing pure oxygen under pressure.
That's the one. Now, initially there were some concerns. People thought, well, if free radicals involve oxygen, maybe giving more oxygen will make the IR injury worse.
That makes intuitive sense, actually.
It does, but numerous studies have since shown that theory isn't correct. It seems acute HPO2 therapy does not worsen IR injury.
Okay, that's definitely good news. So what does it do? What are the benefits seen in studies?
Well, the animal studies show some significant positive effects, in models using skin flaps, for example.
Like tissue used for reconstructive surgery.
Exactly. HPO2 treatment during reperfusion significantly improved the survival of these flaps, and it increased blood flow within those tiny microvessels. It even helped that the flaps experience a second bout of reduced blood flow later on.
That's encouraging. What about skeletal muscle? We said that's particularly vulnerable.
There, too. HPO2 has been shown to reduce both edema, the swelling, and necrosis tissue death in animal models of tourniquet ischemia or compartment syndrome.
Reducing swelling and tissue death sounds crucial. How does it do that? Is it just the vasoconstriction effect of oxygen?
Well, vasoconstriction is a known effect of hyperoxia, and it might help reduce capillary pressure and thus swelling in some contexts. But the authors suggest it's unlikely to be the primary mechanism for reducing edema in limbs. The effects seem more complex than just squeezing the vessels shut.
Okay, so maybe not just vasoconstriction. What else is happening, especially in that microcirculation battlefield?
This is where some of the most compelling observations come in. Dr. Zamboni's work again.
Right.
His team demonstrated a really significant reduction in the number of leukocytes, those neutrophils specifically, adhering to the inner walls of the venules in tissues treated with HPO2 during and right after ischemia.
So fewer white blood cells sticking to the damaged veins.
Dramatically fewer. The walls of these small veins actually remain clear of these sticky cells in the HbO2-treated groups.
Wow. That seems like a direct counteraction to that first step we talked about.
It really does.
Mm.
And interestingly, even when they started the HbO2 therapy, an hour after blood flow was restored, it still provided some benefit, although it wasn't quite as effective as starting it earlier.
So timing matters, but later might still be better than never.
That seems to be the suggestion. And connecting back to the arterioles, HbO2 therapy also prevented that progressive narrowing, that vasoconstriction that was seen in the untreated ischemic vessels.
So it stops the sticking in the venules, A&D stops the clamping down in the arterioles.
That's what the studies indicated. And importantly, HbO2 had no effect on leukocyte sticking or arterial diameter in muscle tissue that hadn't been subjected to ischemia.
Okay, so it's not just randomly affecting normal vessels, it specifically targets the pathological changes happening during IR injury.
Precisely. It suggests a very specific effect on the IR injury process itself. And while that study couldn't really look at much later HbO2 treatment because the tissue just deteriorated too much over time,
Right.
the findings strongly suggest that the timing of HbO2 administration relative to the IR injury is pretty critical for getting the best results. Early intervention seems key.
And is this just a local effect, right, where the HbO2 is applied? Or is it broader?
That's another interesting point. The benefits seem to have systemic components as well. It's not just acting locally at the injury site.
Okay, so what are the mechanisms? How does breathing oxygen under pressure stop neutrophils from sticking?
That's the million-dollar question, and it's still being actively researched. But the chapter offers several important clues. One potential mechanism involves superoxide dismutase, or SOD.
SOD, that's an enzyme, right?
Yes, it's a natural antioxidant enzyme in our bodies. It acts as a scavenger, neutralizing those damaging superoxide free radicals we talked about earlier.
Okay.
And studies found increased SOD activity in ischemic skin flaps treated with HbO2.
So HbO2 might boost the body's own defenses against those initial free radicals.
That seems to be part of the picture. By boosting SOD, HbO2 might indirectly lessen the signals that attract neutrophils and make them stick to the vessel lining.
Makes sense. What else?
Well, other research suggests that hyperoxia, the state of increased oxygen, might alter the pathways of free radical production in a way that actually reduces lipid peroxidation.
So it could stabilize the cell membranes, the vessel lining?
Potentially, yes.
Yeah.
Making the endothelial cells less damaged and therefore less likely to attract those inflammatory neutrophils. And importantly, addressing earlier concerns, HbO2 doesn't seem to cause neutrophils to get trapped inappropriately in the lungs in this specific context of IR injury.
That's good to clarify. What about directly affecting the neutrophils or the vessel wall?
Yes, there's work on that too. Research by Dr. Tom, initially looking at brain reperfusion injury, showed HbO2 might influence the pathway leading to the formation of xanthine oxidase, that exoenzyme we mentioned. And perhaps even more directly relevant here, Tom's research on human neutrophils demonstrated that HbO2 can actually inhibit the function, not necessarily stop the cell from making it, but stop it from working properly of that CD18 adhesion molecule on their surface.
The key molecule that lets them stick.
Exactly. HbO2 seems to jam the key, effectively preventing the neutrophils from sticking tightly to the vessel walls and releasing their harmful enzymes. This finding aligns perfectly with what Zamboni observed in the muscle microcirculation studies.
So it interferes with the stickiness mechanism itself.
It appears so. And there's even newer evidence suggesting how it might do this. It seems to involve a subtle qualitative change in the CD18 molecule, possibly through alterations in a signaling molecule inside the cell called cyclic GMP.
Cyclic GMP.
Yeah, and this change might even reverse that capping phenomenon, the bunching up of the CD18 molecules preventing the neutrophils from getting that super strong grip on the endothelium.
So it stops the Velcro patch from forming properly?
That's a good way to think about it.
Mm-hmm.
And it's not just acting on the neutrophils. Other studies show HbO2 can affect the endothelial cells too.
How so?
In vitro studies done in lab dishes show HbO2 can decrease the amount of ICAM1 displayed on the surface of endothelial cells.
GlyCam-1, that was the lock for the CD18 key, right?
Exactly. So fewer locks available means fewer places for neutrophils to bind.
Okay, so it affects both the key and the lock.
It seems that way. And there are in vivo studies in living organisms that corroborate this, showing reduced ICAM1 expression and improved flap survival with HbO2. There's also evidence suggesting HbO2 can switch on antioxidant genes within the endothelial cells, making the vessel lining itself more resilient to oxidative stress.
Boosting the vessel wall's own defenses.
Right. And another major player seems to be nitric oxide. NO.
We mentioned NO earlier helps relax blood vessels.
Yes, and it also plays a role in regulating neutrophil adhesion. Research suggests that HbO2's ability to interfere with that CD18 clustering on neutrophils might actually work through a nitric oxide-dependent mechanism.
So NO is somehow involved in stopping the stickiness.
It appears to be. Studies have even shown an increase in the genetic instructions, the mRNA, for making endothelial nitric oxide synthase, or ENO, the enzyme that produces NO in vessel walls.
Okay.
An increase in ENOS mRNA in ischemic muscle treated with HbO2. And interestingly, they saw this increase even in non-ischemic lung tissue in the same animals.
Suggesting a systemic effect again.
Exactly. And importantly, if you block nitric oxide production pharmacologically, some of the beneficial effects of HbO2 on neutrophil adhesion are actually reversed.
Wow, so NO seems really critical to how HbO2 works here.
It looks that way.
Yep.
There are studies showing increased NO in other tissues like the brain and aorta with HbO2 as well. The ENO-S pathway in the microcirculation seems particularly important for these protective effects against IR injury.
It's such an intricate interplay. Is anything else involved?
One more potential regulator mentioned is vascular endothelial growth factor, or VEGF.
VEGF, isn't that involved in growing new blood vessels?
It is, but it likely has other roles too. They noted increased VEGF transcription in ischemic muscle. And interestingly, using an antibody to block VEGF seemed to reverse HbO2's beneficial effect on neutrophil adherence. So VEGF might be another piece of this complex puzzle.
Okay, so we have all this fascinating basic science showing how HbO2 seems to counteract IR injury mechanisms. How does this translate into treating actual patients?
Well, the research strongly emphasizes, and it's important to repeat, that the primary approach for severe extremity injuries with compromised blood flow is still surgical restoration.
Right, you have to fix the underlying problem first. Stabilize fractures, repair arteries.
Exactly. Fasciotomy for compartment syndrome, replantation if possible, those interventions are absolutely critical.
So where does HbO2 fit in then?
It seems to be emerging as a really valuable adjunctive treatment, an add-on therapy, especially in situations where there's a significant risk of reperfusion injury, particularly in skeletal muscle that has been ischemic without good blood flow for a prolonged period. The chapter suggests looking closely at cases with more than 4 to 6 hours of warm ischemia time.
Okay, so longer periods without blood flow put the muscle at higher risk for IR damage upon reperfusion.
Correct. And given that much of the microcirculatory damage seems to happen within those first 6 or 7 hours after blood flow is restored.
Starting HbO2 treatment early is likely crucial.
Paramount, yes. Early treatment seems key, and many medical centers are now incorporating HbO2 into their protocols for patients with revascularized or replanted limbs, especially after prolonged ischemia.
Are there other uses?
Yes, also for failing free muscle flaps, like muscle transferred for reconstruction if they experience a secondary loss of blood flow. The chapter even shares some anecdotal accounts.
Not controlled studies, but observations.
Right. Anecdotal accounts of treating patients who had up to 14 hours of ischemia with surprisingly good muscle survival and reduced swelling after receiving HbO2 as part of their care.
14 hours is a long time. That's impressive if HbO2 helps salvage the muscle. Are there practical issues with giving HbO2 in these situations?
The chapter touches on a couple of things. Sometimes patients coming out of anesthesia can have trouble clearing their ears to equalize the pressure during the HbO2 treatment.
Ah, like when you're on an airplane.
Exactly. So in some cases, they might prophylactically place tiny tubes in the eardrums, myorotomy tubes, to prevent that problem. But overall, the treatments themselves appear to be generally well tolerated by patients in this context.
That's good. What about the level of clinical evidence overall? You mentioned anecdotal reports, but what about more formal studies?
That's an important point to address. The authors acknowledge that the current body of clinical evidence, while definitely encouraging, does have limitations.
How so?
Well, a review of the literature found mostly retrospective studies looking back at past patient outcomes or studies without a proper control group for comparison, or just case series, collections of individual patient stories.
So harder to draw firm conclusions.
Right. There was one prospective trial designed to look forward, but it apparently had some design challenges that limited its interpretation. However, the majority of these studies, despite limitations, did suggest a beneficial effect of HbO2 and, importantly, with few major complications reported.
So the signals are positive, but we need stronger proof.
That's the takeaway. While the initial clinical findings are promising and many centers are using it based on the strong basic science in these early results, the authors really underscore the ongoing need for more robust research.
Like what kind of research?
Well-designed prospective studies where patients are randomly assigned to either receive HBO2 or standard care, for example. Randomized controlled trials, or RCTs. Those are needed to definitively prove the benefits of HBO2 specifically for treating IR injury in humans.
Okay, so summarizing HBO2's protective role based on this research, what's the main message?
I think the clearest message is that acute HBO2 therapy does not worsen IR injury, contrary to those early fears. In fact, there's a substantial amount of experimental evidence suggesting it actively works against the injury cascade.
And the key mechanism seems to be.
The preservation of the microvasculature, specifically by blocking that initial neutrophil endothelial adherence, stopping the sticking, and inhibiting the subsequent harmful arterial or vasoconstriction, that clamping down.
Protecting the tiny blood vessels seems central.
It really does.
Yeah.
And the potential applications might even go beyond limbs and flaps, right?
Yeah, the text suggested potential in other tissues affected by IR: brain, intestines, kidneys, heart, based on some basic science and animal models.
Exactly. So there's broad potential being explored.
Ultimately, then, it sounds like there's been significant progress in understanding IR injury and the potential for HBO2.
Definitely. Huge progress in understanding the complex processes involved. But there's still a real need for more work, both further basic science to unravel all the mechanisms fully, and those well-designed clinical trials to really nail down its effectiveness and define its role in treating this challenging condition.
Okay. So just to recap for you listening, we've taken a pretty deep dive into this damaging cycle of ischemia reperfusion injury. We've uncovered the crucial roles of those highly reactive free radicals and all the chaotic activity happening down in the microcirculation.
Yeah, that sticking of neutrophils, the vessel constriction. Yeah, it's quite a cascade.
Right. And we've also explored the really promising evidence suggesting that hyperbaric oxygen can act as a countermeasure. Primarily, it seems, by targeting that initial sticking of neutrophils to blood vessel walls and preventing the harmful vasoconstriction that follows.
And interestingly, understanding these fundamental events, down at the cellular and molecular level, can directly influence how doctors approach and refine treatment strategies in really challenging medical situations, like severe trauma.
Wow.
Like trying to save injured limbs and restore function.
Absolutely. And on that note, here's maybe a final thought for you to consider. Given this intricate dance of cellular and molecular events that unfold in IR injury and the multifaceted ways HBO2 seems to work, what other potential therapeutic targets might be out there? Or maybe combination therapies? What might emerge from future research to further minimize this whole damaging process?
That's a great question. It really makes you think about the continuous evolution of our medical understanding in such a critical area. There's likely still much more to discover.